Hello, everybody. Welcome to today's webinar, Medical Providers Working with Oral Physicians. Before we begin, let's go over a few housekeeping items. If you're on the line and have not yet connected to the webinar, please click the link in your confirmation email. Your browser may prompt you to download and run a file. When you're connected, you should see the presentation on your screen. If you have questions, you can send them via WebEx's chat function. Please take a moment and find the chat bubble icon near the bottom and center of the webinar screen. You can type and send questions throughout the presentation. We'll compile them and take time at the end for answers. This webinar is being recorded, and a copy will be made available to all attendees after the event. Now it's time to begin. Laurie, the time's all yours.
Hi there. Thank you all for attending. I know this is kind of a strange webinar, but I really truly think it's vital as far as helping bridge the gap between dentistry and medical providers. So that's kind of what we want to share, what we do on the dentistry side with medical treatments for your patients. So a little bit about me, as soon as I can get this to work. It's not wanting to work. Okay, there we go. A little bit about me. I'm a certified professional coder as well as a biller with AAPC. I work with oral systemic in a large perio office here in Seattle. Saw that dental patients had oral systemic conditions and were not being able to be treated due to cost. And so working with the physicians in this area helped them get better faster, helped their out-of-pocket costs be lower, as well as just the relationship that we could build with our physicians here. I saw that in dentistry, medical billing was a challenge. And so we wanted to be able to share this with other providers to let them know we are medical billers. We do bill medical for medically necessary dentistry. It did help our patients to move forward as well as the providers to know that how we would care for them. The success that we saw with our patients would reduce, of course, their out-of-pocket costs, and they would start to be more compliant with their physician. And so then we wanted to make that connection and help medical providers see how we could join together in order to help their patients get better faster as well as with less out-of-pocket costs. So that's a little bit about me. I'm also the director of the Medical Billing Education Program for Devdent, which stands for Developing Dentistry. Why should we work together? We want to increase that case acceptance for your patients to decrease their noncompliance with their medical conditions in order to help the doctors enable the success and reduce their complications. Physicians can guide patients to dental providers that bill medical insurance. One of the things that I found the most difficult was with medical providers, they don't know who might be able to bill medical for the patients that they're treating and the conditions that they have. We're finding that HMO providers are needed to enable benefits for their patients. We cannot treat HMO patients without a referral from their PCP or primary care provider. We're also seeing comprehensive care is referred to a mutual dental provider. So we want to be comprehensive. We want to work together, collaborate with you. And basically, dental providers can help get your patients in compliance with their diabetes and other oral systemic diseases. In decreasing the medical noncompliance, we're looking at helping with 3D imaging, the appliances that we can fabricate to help with jaw, facial pain, oral surgery, perio, screenings, and more, as well as the procedures due to trauma. I did a survey in California, and they did a recorded survey that 46.8% of the cases in the emergency room were all dental related, in which the physicians could not help them. And we want to kind of bridge that gap so that you would know where to have them or where to send them. So the goal is that we can show you what we can do with dentistry and how we can help make your procedures easier, faster, as well as collaborate together. So the first one would be for noncompliance for diabetes. And patients with diabetes are more likely to have periodontal disease than other people. More likely because they're susceptible to contracting infections or being in contact with infection, as well as it sustains and increases their A1C levels. So we found that if we can help reduce the periodontal infection, we can also help reduce their A1C levels. We've worked with quite a few type 1 diabetics as well as type 2 in getting their A1Cs in a more manageable state, utilizing laser therapy for infection control and reduction. So one of the ways that we would want to be a collaborator with you for your patients. We also know that obstructive sleep apnea has more than just lack of sleep, so to speak. Patients with OSA are more likely to have depression and acid reflux, adult asthma, breathing trouble, liver problems with low OSAT levels, high blood sugar, memory loss. In fact, I was reading an article recently about the type 3 diabetes with the Alzheimer's link. With mental confusion, they have an immune system that's been weakened, hypertension, heart problems, abnormal cholesterol, and fatigue. Sometimes we can see this, the inflammation in the oral cavity that could have something or could migrate to the heart and either go from the oral cavity to the heart or the opposite. Doctors Bale and O'Neill are big advocates to help us be able to get this inflammatory link so that we can help the physicians with their patients to reduce their risk of inflammation. Reduced complications. So one of the things that we found that we want to help with is that your diabetes control, again, the A1C levels, we want to be an advocate to send them to you. If we find a patient that has a family history or gestational diabetes, we will do an A1C test in office. And with that, we are only screening them in order to send them over to you. And in doing so, we want to be the advocate to say, you tell us what would be best. And we want to make sure to get that A1C under control. Personally, this is a huge one for me. My brother lost both of his legs at the age of 57, above the knee, having an A1C of 13. And not that dentistry had anything to do with that, but he did have an extraction the week before, and had they been able to help do the screening to get him to his medical provider sooner, I'm not saying it might have stopped the progression in order for him not to have lost his legs, but I think it would be a great tool to make it imperative to the patient to say, we really need a complete screening through your medical provider. The Parkinson's disease, when I was looking this up, we found that too much saliva can lead to fungal infection in the corners of the mouth. And then too little saliva can also increase the risk of caries. So we want to be able to treat your Parkinson's patients. In Seattle at our office, we see our Parkinson's patients once a month for perio maintenance. That's going subgingival, basically getting out all that bacteria in order to help them with the oral control, either with too much saliva or too little saliva, and being on top of that, as well as billing the medical insurance for a preventative service so that we can maintain them at the best way possible from their physician. The same with Alzheimer's disease. We have the same protocol for our Parkinson's patients as our Alzheimer's, where oral care is vital to prolonging the progression of this disease. We see those patients monthly and collaborate with their primary care provider in order to show levels of where they're at, where they were, and then the medical doctor corresponds with us to let us know what areas they see that need improvement for this patient. Sjogren's disease or Zika syndrome. We found many patients with that have severe caries because of the decreased salivary production. It leads to severe erosion. Now, we can't diagnose the Zika syndrome. We can only see the result of it, in which we so want to work closely with the medical provider so that we can do the best job for the patient to keep them healthy, to keep them out of an emergency room and out of a hospital. Along with pregnancy, the Case Western study of the stillborn baby and the bacteria in the umbilical cord was the same as the moms. We believe that oral health is vital for these pregnant patients. Having a daughter that's due to have a baby next month, The first thing I said when she told me was, please go see your dentist and your doctor. And we want to work together because there are so many conditions that can come up because of pregnancy, whether it be gestational diabetes, whether it be pregnancy granulomas. There's a lot of increased pocket depth and periodontal disease that could come about because of the pregnancy. So we definitely want to collaborate, work with you so that we can help your patients have a very healthy baby and healthy mom. The gastric conditions. Now, of course, the oral physician cannot diagnose GERD or acid reflux, but we can see the result of it. And our goal is that we get them to you as soon as possible. And we want to develop the relationship with the medical doctor so that you know we're billing medical. We know you're looking out for specific conditions, and we want to work with you and collaborate and tell you what we found, what we've treated, and what we've done. The gastric conditions can be anywhere from Crohn's disease to acid reflux, and it extends further because of the digestive system. The heart disease and the inflammatory conditions that we spoke about a little while ago can be in part because of the periodontal disease and that inflammation and bacteria. The C-reactive protein test, there are times that's really not in our scope. And we would want to have them see you in order to do that testing to see if there's an inflammatory marker present. And that would definitely help us to be able to reduce that inflammation once we know that it is present or it's not present, and maybe there's another contributing factor towards that. We want to guide our patients. We want you to guide your patients to us, and we want us to guide our patients to you. I recommend finding dentists in your area that are willing to bill medical insurance. I truly believe with all my heart that dental insurance is not going to be maintained by itself. I think that it's going to be intertwined with medical, especially with the ADA form that basically makes them diagnose now, and they don't even know that they have to. So I really think that we need to be more collaborative with our oral physicians and our medical doctors, and realize that our doctors want to work with you. The dentists are looking to work with you. They truly want to be a part and help your patients get better faster. And the goals are the same. We want health for our patients. We want them to be less stressed, less sick, less down. And in doing so, I think it's a huge collaboration between the two of us. The partnership is great. We can help each other to be able to help our patients. Again, at the bottom, as I stated, we can help each other, and that's our final and ultimate goal. Regarding the HMO plans, we are only allowed to treat HMO insurers for emergency treatment, and that is basically to get them out of any kind of discomfort, but to move forward to get any kind of mastication for dysphagia or any kind of problems in that realm, we can't do that without you. The HMO guidelines will only allow dental treatment for medical conditions if the primary care provider recommends it. Again, the clinical guidelines for Aetna and Blue Cross denote this collaboration between the dental provider and the medical physician. So we want to bridge the gap. We want to be there for what you need us to do, and we want to send those patients that we see some red flags and send them to you to get that treatment done as soon as possible. The care should be the responsibility of all providers, and we want to basically reach out our hand and say we want to be that person to help with your patients in the areas that you can't treat, and vice versa. We want those patients to come back to you to get the things treated that they absolutely were finding in our screening tools. So comprehensive dental procedures for medical necessity. I just wanted to kind of go over some of the things that we do that could help you understand what I might be speaking about. Number one, we provide stabilization of bone to maintain nutrition. If there is not enough bone to maintain, people end up not eating what they should be eating, and end up eating poorly because of the fact that it's uncomfortable to chew. We also utilize laser tissue therapy. to eradicate that bacteria under the gum line. We also utilize that with frenectomies and for infants, releasing tongue ties and lip ties. We want to remove the dental caries due to xerostomia due to that Sicca syndrome. It's going to help overall when the patient has full function of the oral cavity. I don't know about you, but I've had a toothache, and that was while I was in dentistry, and it gave me a great empathy on patients to help me know what they were experiencing. We want to provide preventative care for your pregnant patients with close monitoring. We do recommend pregnant patients see their dental office at least every 3 months while they're pregnant. And then after they deliver, again, can go back to that 6-month regimen as usual. But within that time frame of pregnancy, we want to make sure that they do have close monitoring in conjunction with their OBGYN doctor. The CBCT cone beams with the 3D images, we use those to get clear radiographs. In our practice, we've actually been able to diagnose an amelioblastoma, which ended up with our patient only losing maybe 2 millimeters of his jawbone on the mandible. And so we find that, we want to be a partner with our physicians. We want to say, this is what we found. We're sending it over to you. We'd like you to see this patient as soon as possible, in which his medical doctor did get him in the same day that we found it. And he was able to treat him as aggressive as possible to minimize the bone on the mandible to be lost. The oral cancer screenings with A1C readings, we want to be there. If you have a patient that has a family history of diabetes and/or has had gestational diabetes, we want to screen them about every year, only to make sure that everything looks good, so that if we were to need to do treatment, that we would be able to, as well as if they need more complete health history or panel done by their medical doctor, that we can make sure that gets done as well. We want to make sure our soap notes are written consistent for medical necessity. We don't consider this dentistry. When we're treating bacteria and infection, those are not things that are dental. Those are medical issues that need to be treated, and it's our firm belief that it needs to be treated by both the dental office and the physician office. So this is why we do what we do. This young girl is 18 years old and she has ameliogenesis imperfecta. Her medical doctor wrote her letter so that we could be able to get her coverage through TRICARE. And TRICARE was able to come through and make the payment so that her parents, who had no funding, she was able to get restoration and reconstruction of her oral cavity. By the time we got our authorization, this young girl had 8 teeth left in her mouth at 18 years old. Now, the picture on the right is a picture of what I always say she had imperfecta and now she has perfecta. And she's an amazing young lady. She got her GED. She's heading to college and has a job now, whereas she was not like that when we saw her before her surgery. And so we want to work with you. Believe it or not, her medical doctor came to this surgery, and everybody was in tears because they were tears of joy, just so happy for this young lady. So I want to show you that this is what we want to do as a partnership with the physicians, is to be able to care for people like this. See, and I got through pretty easily, didn't I? In about 19 minutes. I just really want to emphasize how much we want to be a part of the physician world, in that we want to collaborate and we want to make sure you know what we're doing and what we're looking for, as well as what you need from us, to kind of be going back and forth in our collaboration and comprehensive care, keeping our patients out of the hospital and keeping them healthy as much as possible. So I'm not sure if anyone has any questions. I don't even know how many people are on here.
As a quick
There.
reminder, if
Oh,
you'd like to submit a question, please move your mouse to the bottom and center of your WebEx meeting screen. You'll see a row of buttons pop up, and one of them will have a chat bubble icon. Just use that to type in your questions, and then anything that comes in, I will read out for Laurie to answer.
so I guess while we wait and see if anyone has any questions, when we do our education for our dental offices with medical providers, we always provide them a collaboration report, which is one-sided for the oral physician to complete, in that what the dentist sees when they do their examination, to send over to the physician so that they can see what we're seeing, as well as what their recommendations are. So we absolutely want to be the partner to follow through with the recommendations. And we want to be there if you have a patient that has infection in the oral cavity. We would like you to know we're going to build their medical. And so finding those offices throughout, and I know especially in Utah area, we've actually trained quite a few offices on medical billing so that they can be able to provide a service to your patients that is beyond the dental issue. A single tooth of caries is not a dental issue. That is not a medical issue. I apologize. That is truly a dental issue, and we want the dental benefits, which should be there for dentistry. The truly dental issues that those patients might have. For instance, I did a research on dental insurance and how that was created. It was created in 1954 when the ILWU union and the PMA union got together, wanted to provide their union members with something for dental. They got together with the Washington Dental Association and came up with an insurance plan for dentistry. That insurance plan gave those patients in 1954 $1,000 a year as an annual maximum. Within that, an average cleaning was about $6. An average x-rays were $5. An exam was maybe $10 or $12. And so you can see that $1,000 a year that they gave them would take them quite far. Well, this same union in 1988 knew that dental insurance was not going to be the only thing they could provide for their union members. So they created something called the trust fund down in California. It is not part of their dental and it is not part of their medical. It is there for a reconstruction of the oral cavity. And so we are able to help access those members to be able to get full mouth reconstruction, which normally costs about $60,000, to an out-of-pocket of about $10,000, which is much easier. It has sustained their life, their health, their nutrition, and given them more time than the doctors actually thought they could have. So the same union that created dental insurance knew that the dental insurance would not be providing the benefit, and that the $1,000 a month or a year that they gave them to use was taken up quite quickly. Because back then when you had a cleaning for $12, your cleanings now are about $233. Your x-rays back then, as I said, they were $6 now, or $5, and now they are at least $150 to $200 for the x-ray images. And so I say that to say this, that they started something so that they can be able to provide oral care for their patients in a venue that is not through the dental and not through the medical, but it's absolutely something beneficial for their union members. So I hope that gives you a little history on dentistry and maximums. And believe it or not, the maximums are still $1,000 a year with a high of about $2,000 a year.
I don't see any questions coming in. Perhaps what we'll do is we'll hang on for a couple of minutes and see if additional questions start trickling in. We can stop the recording and still answer questions for a little while. So we'll give it a couple minutes.
Just give you a little bit of how to get to me if you have any questions after the meeting, or if you just want to see who in your area might be providing medical billing for customers that you are working for or want to work with. And again, I am holding a meeting, I believe a 2-day course in Utah sometime in May. If that's something that interests you and you want to learn about what we do and how we teach, we'd certainly be glad to do that. We really, truly believe that between the specialties that we can help our patients get healthy faster as well as maintain that health.
A question just came through. It says, is there a good way to bill medical if you can't run it through your clearinghouse?
As far as with a paper claim? If
I
it's with a
suspect
paper
that that's
claim,
the question, yeah.
we definitely try to teach how to do it through a clearinghouse, but we also do teach them how to actually fill out the claim form. I know that there are some offices that are not ready to go to a clearinghouse, and we don't want to write that off as that you're not able to do that. Although the providers are, some of them are not even accepting a paper claim, but it's definitely something that we would absolutely train our dental offices on how to do.
Thank you. If anyone else has a question, go ahead and submit it now through the chat box.
Well, again, I can also talk about the osteoporosis as well as the bisphosphonate use. I really feel that between the medical doctor and the oral physician, we have to work closely on those patients due to the nature of do they need a bariatric chamber prior to treatment and after treatment, and we don't know that because we don't know that side of that patient's medical history. So we always try to push to make sure we get the information. So we really want to work with our medical doctors regarding this. Like I said, we don't have the answers on the bisphosphonate, but we have a huge precaution as far as the care for those patients. And so please know that that's an area that there's nothing we can do as far as we don't know what the best treatment is, and we really need your help in that area.
That's some really great information. We haven't had any other questions come in, so I think what I'm going to do is I'm going to stop the recording. We'll hang out here for a couple minutes in case something else comes in. And of course, Laurie has provided her contact information for anyone who wants to ask her questions offline. So for anyone who doesn't have a question and feels like they are complete for this session, we thank you for your time. We hope that you learned something and found it enjoyable. And we invite you to come check out our events page at uhin.org/events. We have monthly webinars and sometimes additional guest speakers coming in. And we're really excited to always offer something new. I did just get a message saying that some people are having trouble sending in questions via the chat box. We've been getting some chats, but if you're having any trouble, please go ahead and send an email either to Laurie with her email address or send something to UHIN at education@uhin.org, and we'll coordinate with Laurie to get your questions answered.
Absolutely.
So, thank you again for your attendance.